Studied at the University of Virginia. He completed his MD and PhD at WashU in neurology and neuromuscular fellowship at the University of California, San Francisco. And then he did a postdoctoral fellowship at UCSD. He's now a professor at WashU in St. Louis, and notably has led the development of tofersen from his lab through phase 3 trial and ultimately to FDA approval. He's going to talk today about asymptomatic gene carriers and using ALS gene-targeted therapies in the consideration of early diagnosis and treatment, which was something that came up in the chat already. So, Dr. Miller, thank you for being here.
Delighted to be here and to take part in the conference. Can everybody hear me okay?
Yes.
Okay, great. And I'll just say up front that I'm sorry that I won't be here later this afternoon. Hopefully I will leave time for questions. I have the ALS clinic this afternoon, so can't be here. I'd just start by recognizing my industry collaborations. Ionis Pharmaceuticals, with whom I've had the pleasure of developing antisense oligos, and I'll talk about those today. And Biogen, with whom I've had the pleasure of running clinical studies, and I'll talk at least about one of those studies today. I think this probably needs little introduction, the genetic landscape of ALS. I'll just remind you that 10% is familial, and among that 10%, 10 to 20% of that is SOD1 or superoxide dismutase 1 to 2% of all ALS. So it's about 300 to 350 people in the United States. And I'm going to talk about the tofersen program, and then I am going to get to the asymptomatic piece. Bob Brown and James and Merit asked me to discuss some of that and bringing that into the context today. So I'll review quickly, hopefully, some of the tofersen data. I think many of you have seen this before. The rationale for lowering SOD1 is pretty clear. The main point is that mutant SOD1 acquires a new toxic property. That's true for multiple genes in the ALS space. We think that decreasing SOD1 is likely to be beneficial. We're using antisense oligonucleotides. You're going to hear later on today about other ways to lower SOD1, other ways to target the RNA, and then I think broadly other ways to think about modifying genes related to ALS. So the approach we're using here is antisense oligos. These are 20 mers. They're DNA-like or RNA-like chemicals modified at the backbone, modified at the 2' position. The modifications increase the binding to the target RNA and increase the stability in biological fluids. They also importantly help to evade the immune system. They get in by mechanism not understood, get into the cell, taken up by the cell, moved into the nucleus. In the nucleus, they bind to the RNA and then activate RNase H, which degrades the RNA, and then the protein and the RNA fall according to the protein half-life. And this is some of the early data in cell culture for SOD1, showing you 2 successful antisense oligos that we then brought forward and put in the intraperitoneal cavity of a rat. And we lowered SOD1 in the liver and the kidney, but we had no effect in the brain. As you might expect, these large charged molecules don't get across the blood-brain barrier. But if you put a hole in the blood-brain barrier, as has been done routinely by neurosurgeons, or could be done through a lumbar puncture, as is shown here in this diagram, you can deliver the antisense oligos into the CSF, and then perhaps surprisingly, and I won't get into that older data, but clearly distribute throughout the brain and the spinal cord. And then when we put those into a rat that expresses a mutation in SOD1, the mutation causes loss of motor neurons over time in this rat model. And I won't go through all this data. I'm just going to show you my favorite figure from the mouse and rat data. And that's showing you the compound muscle action potential, the amplitude here. That's the summation of the electrical activity of the muscle after maximally stimulating the motor nerve. If you're losing motor neurons, as these animals are, you would expect the compound muscle action potential to go down. And that's exactly what's happening here in both of these groups. Now, for one of the groups, we're going to give an active ASO, the other an inactive ASO. And you can see that this is intracerebral ventricularly delivered, so delivered to the CSF space. And the group with the active ASO the compound muscle action potential starts to go back up. So we're reversing some of the decline in the compound muscle action potential, something that we'll be looking for in humans as well. There were toxicology studies in phase 1 and phase 2 studies. I'm skipping all of that and going to the phase 3 study, the Valor study, which was published in 2022. Tofersen is the name of the antisense oligo that lowers SOD1 RNA. There are 72 people on drug, 36 on placebo. And this is showing you the dosing regimen, 3 doses in the first month and about the dose given about once a month after that. And that continues. And for some people, this is now continued for 5 to 7 years. Just reminding you again that we're delivering this through the intrathecal space. So this is intrathecally delivered like a lumbar puncture because it doesn't cross the blood-brain barrier. SOD1, antisense oligonucleotide tofersen, lowers SOD1. This is not a surprise, but it is important to see that we did indeed lower the levels of SOD1. Again, here shown, this is the group that gets the drug early. This is the group on placebo. I'll point out at 28 weeks is the beginning of the open label extension. Everyone had the opportunity to go on drug at this point. 88% of the people in the trial chose to go on drug. And you can see then that their SOD1 level is lowered as well. Just want to comment about neurofilament. Neurofilament levels are high in the setting of ALS. Here's ALS compared to other neurodegenerative diseases, so particularly high in the setting of ALS. And neurofilament, an intermediate filament protein in the part of the structure of the axons, does matter for ALS. So this is showing you that the level of neurofilament predicts survival for those with a high neurofilament. If you look at 4 years, less than 25% of people surviving, whereas those with a low neurofilament at the beginning, greater than 60% of people surviving. And so our interpretation of the really substantial lowering of neurofilament in this study, here's a group on drug, lowering neurofilament, not on drug until here, and then lowering of neurofilament. Our interpretation of these data is a substantial lowering of the neurodegenerative disease process. And so we then, of course, looked at the function, and many of you know that we looked at the ALS functional rating scale, 48-point scale. You lose points as you go in 4 different subdomains. And that was the primary readout for this study at 28 weeks. And at 28 weeks, we saw some difference, but not much difference. This was a bit of an oh no point in October of 2021 for this study because we didn't hit the primary endpoint. If you look at the same functional rating scale out at 52 weeks, now you begin to see a difference. Here's the placebo, placebo up to 28 weeks and on drug the whole time. There is a difference there. And then if you look at the muscle strength, so this is handheld dynamometry, summation of the muscle strength, multiple muscles over time. And this is the group, again, that got the drug from the beginning, and you see a flattening of the curve here as you look out to 52 weeks. This is my favorite figure from this published study. We went back and looked at this in more detail. So are there, people really flattening out? I guess there is a difference. And I think really importantly, there's, if you look at the group on early start, this group in the red, 27% of that group had an improvement from 0 to 52 weeks. So an improvement in their strength, which is, as many of you know, can happen in the setting of ALS, very rarely, but for 27% of people to have improvement is really a striking number. There are side effects of the drug, likely related to inflammation. The antisense oligos can activate the toll-like receptors. We don't know the details, just know that there were 7% of people on drug compared to people on placebo who did not have these reactions, and you can see them listed here. And these are part of the drug label for Qalsody, which is the name of the FDA-approved drug. I want to highlight just a few anecdotes. There are some powerful anecdotes that have come out of this study and really focused on improvement. And I'll highlight that my Washington University colleagues, as shown here, with a group that gathered these data at Washington University related to tofersen. The first is an expanded access participant, young gentleman, relatively new diagnosis and known to be in a family with a rapid disease course, so he had not progressed very much himself. And what you can see is that his neurofilament also went way down. I think that this was an important finding for us. This is neurofilament measured by the Washington University lab, as run by Dr. Buccelli and Pestronk. So this is measured, it's expanded access, it's measured outside of the clinical trial. This is kind of real world clinical values showing that this person's neurofilament had dropped, his strength stabilized. And we've brought in the physical therapist. I don't have all of these data, and as we're continuing to gather it as we have launched a rehab program in the setting of tofersen-related ALS, so try to help people get even better. But this is some of the early measurements. The timed up and go and the 10-meter walk test are the two to focus on. And the timed up and go went from, it's just that, how fast does it take you to get up and go? This gentleman was using a rollator, from 17 seconds to 12.5 seconds. I was trying to wrap my head around that. And that's Sean Smith, who did these measurements with the physical therapist. And 2.1 seconds is the meaningful change. And you look at the 10-meter walk test, 0.37 to 0.92, so getting faster. And again, 0.15 meters per second is a meaningful change. But it's helpful for Sean to put it into context for me recently, which is to say that the 10-meter walk test at the value shown here is somebody we would predict could ambulate okay in their house. And when you get up to this sort of speed, we anticipate this is somebody who could ambulate in the community. So major functional changes with this kind of improvement. I'll highlight one more story or maybe two more stories before I move to thinking about the asymptomatic population. This is a phase 3 participant. This is somebody that I follow clinically and referred him to the trial at WashU, Bob Uccelli leading the group at WashU. And in the trial, his breathing went down, his functional rating scale went down, and his strength went down. He absolutely crashed. We don't know whether he was on placebo or drug. We assume he was on placebo, but don't know. And he couldn't really get his arm above his head. He was short of breath with talking, unable to walk. And I saw him in a Zoom meeting in 2021 because we were doing Zoom visits at that time. And he said his right arm was stronger. And I said, well, great to hear, but we hadn't heard as much of the improvement. We weren't far enough out to see it at that point. And I was, of course, skeptical of finding improvement. But when we saw him, his breathing had stabilized, his function had come back up, his strength was coming back up. And he showed me, he said, yeah, I can pick my arm up above my head now. I can use my right arm to pour from a gallon jug. He wasn't short of breath with talking anymore. He's now in rehab to learn how to walk. And I think for the neurologists and the clinicians in the audience, these numbers are really striking to me. These are his MRC scale strength, an imperfect medical research council scale, imperfect scale of measurement, where 5 is full strength, 0 is no strength, 3 is against gravity. So 3 is pretty weak. He's pretty weak in a number of these muscles. And then when we tested him again at month 22, he's nearly full strength or full strength in a lot of these muscles and has made substantial gains. For example, on hip flexion, where he's gone from really not being able to move the muscle much at all to having decent strength. So really incredible gains. And he's now, again, in rehab learning how to walk. We looked at his compound muscle action potential. This is the summation of the electrical activity of the muscle after maximally stimulating the motor nerve. And what you can see is that it's flat, stable to increased. To acknowledge that we don't measure this a lot in the setting of ALS, but this would be completely unpredicted. We would not anticipate that the compound muscle action potential would go back up if you're continuing to lose motor neurons. People have asked, well, how could you get there? And I do not have data from the trial to support the hypothesis I'm going to show you, but I think this is likely how it's occurring, which is if you look at the compound muscle action potential, summation of electrical activity, 2 neurons connecting to muscles here, and this neuron denervates. It loses the connection of the muscle atrophies, but this cell next door, this neuron is also sick. It's got ALS. But if we make this stronger, better, lower the levels of SOD1, for example, now this neuron, motor neuron, is able to take over this part of muscle. I'll share with you one other story. There were many from the FDA advisory committee meeting. I just pulled out one today. This woman said that since my first dose, I'm doing things I could not do and had accepted I would never do again. My limp has gone from disability to barely perceptible. I can go into my office again because I'm able to get up and down the subway stairs. I can shower without my shower chair. So some conclusions. I've gone over this. Lowering of SOD1 lowers NFL, increase in survival, which I didn't talk about, but is also there. There are side effects, but there is stabilization of function, breathing, and strength, and in some improvement. And then the FDA approved this drug in April of this year. This is the first genetic therapy for ALS, first intrathecal degrading ASO for neurodegeneration, first accelerated approval for ALS. First drug to have substantial effect on slowing of ALS. Some may quibble with that comment about what does substantial mean? And then first drug to show evidence of clinical improvement in adult onset neurodegenerative diseases, another statement that ought to be perhaps continue to be tested. And what is that definition of neurodegeneration? But really a striking finding from my point of view. There are the lessons learned that the ALS is a treatable disorder and can show improvements, I think, is a really important one for me as an ALS researcher. We need to find the right drug for others with ALS. I think tofersen is a drug for SOD1 ALS. The fact that ASO delivery can be affected is also an important learning, because there are a number of other ASO therapies coming through, or other intrathecally delivered therapies. It's going to take time. This is another point that we're going to continue to wrestle with in ALS is, well, how much time do we need? And if 6 months wasn't quite enough when we lowered SOD1, is 6 months enough in other trials? And how do we read those out? And then neurofilament. I think neurofilament movement will be predictive of success or failure. That's an opinion. We don't have enough data to know that now. It is important to also point out that an effective drug may not change neurofilament. You can think of a variety of mechanisms that a drug could be good for ALS, but wouldn't necessarily change neurofilament. For this part, I do want to highlight a number of the groups that have been involved in this study for now many years. Importantly, also the brave volunteers, the participants in these studies, and the caregivers. They showed up for this about once a month to each of these sites. I want to recognize the steering committee, in particular Merit Cudkowicz, all the principal investigators listed here, and my colleagues Steph Fredette and Toby Ferguson at Biogen. And in case you're worried that I finished yet 10 minutes ahead of my time, no, I've left time for this other piece that I was asked to consider, which is a consideration of early diagnosis and treatment. And I'm going to move to that section. So some considerations for early diagnosis and treatment. Again, a number of these will be my opinions. I think we're still working this out. I do think that these results spark the need for genetic testing for symptomatic ALS. And I'll comment that there are some people who don't want to get genetic testing, but are okay with getting SOD1 genetic testing, and that there's an action item on the other side of it. So there are, I think, as many of you know, 2 free genetic testing programs, which is fantastic. You can also test just one gene. You have to write it down very clearly, but you can get back just the SOD1 result if you wanted to do that, or maybe just SOD1 and FUS. We're going to hear about the exciting FUS ASO program from Neil Schneider, I think, later on today. And so for people who really don't want the full genetic testing, we're guiding them to at least 2 genes that have action items in terms of clinical trial or a therapy right now. Of course, we also consider all genetic testing in symptomatic ALS to be an action item if you find a gene. I think genetic counseling for at-risk family members, and whether that genetic counseling is done formally or by the neurologist, I think that some component of that's going to need to be an ongoing part of our care. And then monitoring program for those at risk. I'll just leave it at that, monitoring. I think we don't know. I'm going to share with you just a little bit of data, but we don't know exactly what to do, how to monitor these people. How often should we check in with them? Should we be doing biomarkers in blood? I can tell you at our own site, we have neurofilament clinically. We get a baseline neurofilament level for everyone at risk. Early is better. I've been asked about that in terms of early diagnosis and treatment. Early is better. I mean, this is just one of the figures showing that this is the group that delayed 6 months. They're not doing as well. And if you look out here, and I didn't bring those data today, the 2-year data, they're still not doing as well as they would have if they've been here. We do eventually slow things down, but we want to get people on treatment as early as we can. And so that's another reason to think about genetic counseling and what are we going to do with those at risk. And it also really pushes us to figure out how to define ALS at its earliest time points. And so maybe this gets to the next question, how we can prevent ALS. There's some challenges for preventing ALS, for it never occurring. The age of onset is highly variable in genetic ALS. This is a big deal, a major problem. When do we start therapies? In other genetic disorders, neurodegenerative disease, they kind of know when it's going to start. In a couple of years within the time that your parent may have gotten the disease. That's not true in the setting of ALS. And so would you put somebody on a drug for 20 years, for example? There's a lack of identifiable prodrome, limited epidemiologic risk factors. We don't know what's sparking it, and a lack of disease-specific biomarkers. There are multiple groups now planning for ALS prevention trials. Started with James Berry and Mark Garay and our group at WashU. I want to highlight the number of these slides on this part of it are from Mark Garay. So thank you, Mark. And also ALS families from Columbia and PreFiles from the University of Miami. We've Dials and families have teamed up together for a study which we call very simply Prevent ALS. Seems like a great goal. Which includes now MGH, WashU, and Columbia, and this is underway. We're evaluating for early changes in a number of different ways. You can think about blood and tissue collection, cognitive assessments, motor testing. I like the picture here of Katie Nicholson, who helped launch Dials at MGH and is now moved on from MGH. Also digital biomarkers and EMG nerve conduction studies, all of these components that we need to think about. The Prevent ALS cohort has more than 200 gene positive people enrolled. About 60% are CNR72, more than 85% do learn their gene status. And 15 to 20 phenoconversion events at this time. They're rare. There are some biomarkers for prodromal ALS, and this is rapidly progressive SOD1 ALS shown here. This is work from Michael Benatar looking at neurofilament, which goes up before people become symptomatic. So this time period here. So how generalizable is that neurofilament change to CNR72? These are data from Adam Stefaroni and Adam Boxer showing that there is, if you look at 0 at the time point getting disease, minus 10 years, in their modeling data, there is a slow rise of neurofilament in the years before. But and I realized as I was putting together this talk and didn't have all the time I needed to really dig into these data and bug the Adams at UCSF about this, like, how does this work out on an individual level? How well can we use this? And I think that those are the kinds of questions that we have about how we can use this in the setting of a trial. If you look at the data, some of the very, very early data from Prevent, in C9 ALS, here's the time point when they convert. Beforehand, we didn't see much change, at least in these two, and there are more coming through, and we'll begin to gather more data. In terms of a preventative trial, there is one that's ongoing. This is the ATLAS study for SOD1 mutation carriers, which is an interesting study looking at neurofilament. So I'll highlight part A, which is the natural history run-in. So you have a gene change, but are asymptomatic, and you have neurofilament measured. And then in part B, it is placebo-controlled. If you have an increase or change in neurofilament, 44 is the number listed here, a change from baseline as well. An increase in neurofilament, then you go into the placebo-controlled portion, either get drug or tofersen, the drug that I described to you that lowers SOD1 mRNA. And then the outcome there is, do people develop ALS? If you become symptomatic, then you go into the open label phase, get on drug. Or if during this phase you become symptomatic without noticing this neurofilament change, you go right on drug. So this will be a really important study to help define treatment early on and the effect of treatment early on, and also the concept of whether we can prevent ALS. Okay. So this is my last slide. James, I was targeting 20-something minutes. So genetic testing for symptomatic ALS, I already went over that, but I think it's an important point. In our field, early treatment is better. I think it's clearly better. And at least for tofersen, we want to get people on a drug as early as possible. I think that's going to be true for all the drugs. Genetic counseling of some sort for at-risk family members, I think, is important. A monitoring program for those at risk, we still don't know what to do, but I think we do want to monitor or think about that, even if we don't have best practices yet for monitoring. We need more early biomarkers. How are we going to know? How are we going to see the change? It might be neurofilament. It's not clear there's going to be neurofilament for all genetic ALS, and it's not clear yet whether we will be able to see that change, for example, in CNR72. I'll just comment about what's the feasibility of an asymptomatic prevention trial in those without a biomarker change? We're not looking for change. We're just going to put somebody on a drug for how many years, and how are we going to follow that? And an example of that would be riluzole in CNR72 gene carriers. Should they be on it? Should they start that? The fact that that neurofilament is slightly up compared to controls may be an opportunity. The normal levels of neurofilament do range. And so maybe we could see a decrease in neurofilament if we were to treat a group very early on, even though that's a very low decrease. And I'll leave it there and just acknowledge the people in my group that have worked on this. Again, thank the participants, funding agencies, and then in particular, the Prevent ALS group focused on how are we going to prevent ALS, how are we going to find these early markers. And I look forward to your questions.
Thank you so much, Tim. I mean, fabulous. Two parts to the talk, but both parts are incredible. There's a lot to be learned. It's been a lot of fun to work together on trying to unravel these earliest changes in ALS, but there's a long way to go, and we have our work cut out for us. That's okay. So there are a couple of questions that have been raised already. One is, does the improvement that we see with tofersen mean, in your mind, that neurons are impaired but not necessarily lost? Is that what we're seeing, or is there something else that may be accounting for that improvement in strength?
I don't have data to support this, but that's my opinion, is that there are sick neurons that are taking over more muscle. And that is a mechanism that's been seen routinely in the setting of nerve injury. And so I think it's highly probable that those neurons are becoming less sick and able to take over more muscle. I do not think we're rebirthing neurons, for example.
Right. So some may have been lost. Those are lost. Some may be.
If they're lost, they're lost.
Right,
which again gets back to the early treatment. If
right.
you've lost the neuron completely,
right.
It's not going to come back.
But it does remind us of sort of, paralytic polio and reinnervation we see after the end of the sort of decline in paralytic polio.
Yes, and those the gains of after paralytic polio happened several years out. A little bit confounded, as I've been told, by the fact that a lot of those were kids that people were looking at, and they were gaining milestones as well. So it's a little bit hard to tell. But my read of those data is that the people made gains, a year or 2 years out in terms of reinnervation. But that's a little bit hard to read.
Yeah, I mean, we see that same phenomenon just in nerve injury, though, as you alluded.
Absolutely.
I mean, all right, and then so there's sort of an adjunct question, which is, is there a way to tell the difference between a significantly impaired motor neuron and axon and one that's been completely lost? Both may have lost their function. How do we? Is there a way to know? Is there a way to differentiate? Maybe that would be a more rational way to sort of say, here's someone that would be a great candidate for a trial. Here's somebody that maybe we've lost a neuron in this region.
I think at present we don't, and maybe someone else has a creative answer to whether we'll be able to tell, whether it's some of the retrograde labeling sort of stuff that Bob Brown and others have thought about. But I don't have a good answer for how we can tell. I think we should make the assumption that there's a number of neurons that can be rescued, that have denervated. Of course, if as soon as you get full denervation, you don't have a connection with the muscle and you'll get full weakness, is one way to think about that. But you're just like millimeters away, just hang on and grow that neuron back. So I think it's gonna be very hard to tell. And I guess I would, what we've seen thus far is really remarkable improvements. And I think it is now up to us to figure out how to make that better. 27% of people getting better is mind-blowing from my point of view.
Yeah.
But wait a minute, that means not everyone got better. I think everyone slowed down is my read of the data. As I look down, I think everybody responded to the drugs. I'm a little bit sensitive to this idea of responders versus non-responders. I think everybody responded, but some people got better. And so how to get everybody better? I think that's a major focus and a goal.
One last question. We've got you. We won't have you this afternoon, so I'm going to run into lunch by a couple of minutes. But Bob Brown asked the question, what's the optimal level of SOD1 suppression, do you think?
Yeah, that's a great question, Bob. I think we do not know the optimal level of SOD1 suppression. My guess is, kind of somewhere between 50 and 90%. I think there are some case reports that you'll be aware of as well that, deletion of SOD1 from birth is probably bad. Whether we can delete, completely reduce like 99% reduction of SOD1 in adults, whether that's okay or not, I think we don't know. But it's likely that high levels, but not completely eliminating the gene is probably the best from that's a guess, though. I don't think we know that from the animal models either. There's no amount of reduction that led to any problems as far as I'm aware in any of the animal models or in adult. So I guess in some, I should have just said, I don't know. I think substantial, not full.
Good. We have a couple more questions that are coming in. I think, given the timelines for today, I think I need to cut this off now, but actually there are, we'll be able to talk about some of these questions as well, even without Tim's presence at our afternoon roundtable, I think. So we'll hold on to these questions. Thank you very much. Thank you to all our speakers for the morning.